Thank you for inviting me to this wonderful weekend. I was present by video previously, so I'm so pleased to be here in person. And you've heard a lot, wonderful science and research. So this is going to be a little bit more of a practical talk about a really common symptom and how to assess and manage bladder symptoms. And as you know, with pelvic organ symptoms, bladder, bowel, and sexual function often all go along together. We've only got 20 minutes today, so we're just going to focus on the bladder, but maybe next year we can do a workshop with looking at those other symptoms as well. So bladder symptoms are really common, and there's not that much in the literature about bladder symptoms and leukodystrophy specifically, but it's common in both men and women. And as you can see, we kind of think about symptoms as being what we call overactive bladder symptoms or storage symptoms, or difficulty with emptying the bladder. But particularly the bladder storage symptoms are common both in males with AMN and carriers as well. And we can see here more than 80% of people reporting urinary tract symptoms. This is also the case with Alexander disease, with 50% in this small group of people reporting lower urinary tract symptoms. And so ordinarily our bladder holds between 200 and 500 mils, and people might pass urine up to 7 times in 24 hours. That's kind of a typical pattern, and once at night. So in a 24-hour period, people may pass 1.5 litres of urine, depending on how much you drink. And actually, the time taken to pass urine in our daily lives is very short. It's only about 3 minutes out of a 24-hour period that we actually spend passing urine. And so urination, which takes more than 30 seconds, is also can be what we call prolonged voiding, so that can be problematic. And where it's important in neurological conditions is that the passing of urine involves all parts of our central nervous system, including our brain, our spinal cord, and the nerves that come out from the spinal cord to the bladder as well. And so depending on where the major problem is with lesions, with neurological conditions, depends a bit on the symptoms that people might experience. Say, for example, if people had mainly a condition that affected their brain with brain lesions, they have what we call storage symptoms. So that's needing to pass more urine frequently, urgency, what we call urgent continence, which is some incontinence on the way to the toilet, and passing more urine at night, nocturia. If there's more spinal cord involvement, then people can have both problems with the bladder being overactive, but also with emptying the bladder as well, what we call voiding, dysfunctional voiding symptoms. And if there's just the very bottom of the spinal cord is affected, which may be in a condition which is inflammatory like MOGAD, then the bladder itself becomes what we call acontractile or floppy. It doesn't contract when it should to empty the bladder. And so as our bladder fills up, the bladder muscle, the detrusor muscle, relaxes. And while it does that, the sphincter, which is the trapdoor underneath the bladder, contracts, and that helps us to maintain continence while our bladder is nice and relaxed and filling up. And while that's happening, the signals, as the bladder fills up, are travelling up the spinal cord, up to what we call the pontine micturition centre and the brain stem at the bottom part of the brain, where a lot of our automatic functions are. And that's giving inhibitory signals saying it's not the right time or place to pass urine, our bladder's filling up, it's nice and relaxed. And then as the bladder's now full, the signals have gone up to the pontine micturition centre, and then goes the frontal part of the brain, the prefrontal cortex. And that's more of the kind of the social context and behavioural context. Is now the right time or place to empty my bladder? I've got to wait to the end of this lecture, so I'll hold on. When it's the right time or place, then that inhibition is released, and then the signal goes back down the spinal cord, and you're able to pass urine as the bladder, the detrusor muscle is able to contract and the sphincter relaxes. Now what can happen is, in neurological conditions, is that anything that disrupts that signal along the way affects those bladder signals. So the bladder can be contracting when it's only half full, what we call detrusor overactivity. And as well, if there's anything that interrupts the signal in the spinal cord, that means the bladder can be contracting when it's ready to empty, but the sphincter, the trapdoor, isn't opening. And so there is a disconnect between the bladder contracting and the sphincter relaxing as it should to allow you to empty your bladder. And so how to assess the bladder, one of the first things we do is assess symptoms. And so that's determining whether symptoms are more of a storage or a bladder filling problem, so with the urgency, frequency, or is it more of a bladder emptying or voiding problem, or a combination of the two. And we assess this with using, obviously taking a history, taking a bladder diary over 1 to 3 days, and then doing what we call post-void residual tests. So that's doing a ultrasound after someone's emptied the bladder to see how much urine's left behind. And then that also determines if any further investigations are needed for ultrasound of the kidneys and bladder, pelvic floor assessment, or urodynamics with a urologist or urogynecologist, looking at the structure and function of the bladder. And then it's also a time to identify any red flags that further specialist care might be required, such as blood in the urine outside of the context of infection, recurrent urinary tract infections, prostate enlargement, prolapse, or any other kind of more complications with catheters. And so as I mentioned, we have the storage symptoms, which are of the bladder itself with urgency, frequency, nocturia and incontinence, and then the voiding symptoms where, for example, hesitancy, going to pass urine, it takes a bit of time for the flow of urine to start, needing to push or strain a bit for that flow to start, and what we call an interrupted stream, where the stream stops and starts as you pass urine. And so there are multiple reasons why there can be incontinence, or this can include the bladder being more active, what we call stress incontinence, which is more the pelvic floor, which is like a hammock of muscles which help us to maintain continence. Sometimes it can be because the bladder's too full, because you're not able to empty it properly. Sometimes it can be toilet access, having the toilet in a different part of the house, and it's difficult to access that in time. And if there's any kind of visuospatial difficulty or apraxias where getting trousers off or getting to the toilet in time is difficult. And so we do a bladder diary, which is something quite simple to do at home over 1 day. 3 days is ideal, but at least 1 day is also really useful. And so that's looking at the frequency and volume of urine passed, the frequency and volume of intake, so beverages that are drunk, and also the type of beverages, because different drinks can irritate the bladder. And it's always really surprising, because I've had people who drink 10 cups of coffee a day because that's been their habit for a very long time, but caffeine's a really strong irritant to the bladder, so a bladder diary is always really useful. And so we use it to calculate the input and the output with the fluid, and also identifying what time people stop drinking fluids. So if the main problem is you're getting up to pass urine all night, we generally recommend to stop drinking fluids 2 to 3 hours before you go to bed. But if you're drinking fluid right up until the time you go to bed and when you go to bed, that's something that can be quite easily identified. And the last thing is to detect something called nocturnal polyuria. So ordinarily our brains are clever at turning off our kidneys at making too much urine during the night time. But in some neurological conditions that doesn't happen, and so you keep making as much urine at night as you do during the daytime. And the only way to really recognise that and find that out is to do a bladder diary. And so this is an example here, and so you can see the type of beverages it's written, the volume in and the volume out. And so the kind of easiest way to do it is to use the same sized cup or mug while you do the bladder diary, then you know exactly the volume that you're drinking. And there are some tips as well to easily capture the urine too. And then we can calculate and see in this example, actually, this person did have nocturnal polyuria because they were producing 50% of their urine at night, which means, if you're up to the toilet 4 to 5 times in the night, that's really disruptive to sleep and quality of life. And so this means that there's some individualization of kind of fluid intake, and this is where the bladder diary is helpful. We generally recommend caffeine reduction as of the beverages that irritate the bladder. Caffeine's a really strong one, as is alcohol, strong fruit juices, and they're sparkling drinks, not sparking drinks, so anything with bubbles in it as well. So caffeine below 100 milligrams a day, and just for reference, a single espresso is about 60 to 70 milligrams. Otherwise, switching to decaffeinated beverages for the rest of the day. And also this radar key scheme, which for a small amount of money you can purchase a key which gives access to radar toilets or accessible toilets around the UK. And so then we would move on to measuring the post-void residual, which is to identify if there's any urine left behind. And so it's anything more than 100 to 150 mils. And that's really important because there may be put you at high risk of recurrent urinary tract infections, because a pool of urine which isn't being emptied is an ideal environment for bacteria to live in. It can worsen the storage symptoms and potentially lead to kind of an overflow incontinence picture. And it also informs kind of the next step of management in terms of medication might be useful. So at the same time, we always dipstick the urine to make sure there isn't a urinary tract infection, which is always important when there's new symptoms. And so this is a kind of a fairly simple algorithm which we follow with comes with urgency and frequency. We test for urinary tract infection, measure the post-void residual, and then if there's less than 100 mils in the bladder, then follow the arrows around to look at different treatment options, one of which might be with overactive bladder medication. If, however, there's more than 100 to 150 mils left behind, then we might need to look at different ways to assist management of the bladder, and that might be with self-catheterization, sometimes medication if there's prostate enlargement. So this is, and I'm sorry it doesn't project well at all, but just as an example, we use questionnaires commonly, and this can be really useful because appointment times are often really short and there's a lot to talk about, but if you can do a urine or a bladder questionnaire, a neurogenic bowel questionnaire, and maybe a sexual function questionnaire beforehand, that can sometimes target particular difficulties that you might be having with your bladder. And depending on what is found, further investigations might be required, usually undertaken by a urologist or urogynecologist. And it's always important to check renal function with a blood test. And so if we look back at the symptoms and the pictures, what people might have, and these general measures, so changing beverages, bladder diary, etc. And these are the sort of measures that people can undertake, so quite simply at home. So bladder retraining or behavioural training of the bladder, pelvic floor exercises, and then we can look at some different appliances to aid continence. And then the second stage would be if still having some significant bladder symptoms after that, what other options are there beyond that? And we'll go through these, which is overactive bladder medications, tibial nerve stimulation might be appropriate for some people, bladder botulinum toxin injections, and then different options for catheterization. And so behavioural training, this is really taking back control of your bladder from your brain. And the classic symptom that people experience is what we call latchkey phenomenon, or key in the door. You've been out shopping, you get home, put the key in the door, and the first thing you need to do is rush to the toilet. And so the idea of this is you come into the door, and instead of putting a timer on your phone, it might only be 30 seconds before you then go to the bathroom, but it's doing some behavioural training to take back that control, and you can build that up over weeks, so you might get to 10 minutes before you need to rush straight away. And as well, if there's some difficulty with emptying the bladder, voiding on the clock, so every 2.5 to 3 hours having a timer on your phone during the daytime if you don't get those sensory signals from your bladder that it's full and you need to empty it. And so Pelvic floor muscle exercises are also really important, and there's a couple of resources, the NHS Squeezy apps people find really useful, and also the pelvic physiotherapist Natalia Vasquez at UCLH. There's a series of YouTube exercises. You can just Google on YouTube this link here, pelvic floor exercises UCLH, and she runs through how to find your pelvic floor and how to do those exercises for both bladder and bowel, so that's a really useful resource. And so then if we move to the next, line of treatments and looking at medication for overactive bladder, there are a number of options. And they're really divided into two families, and that's antimuscarinic and then mirabegron over there by itself, which is what we call a beta agonist. And so deciding which medication best suits you is obviously a conversation with your clinician, because some people just want a very short-acting medication. Say, for example, they've got a long train ride or a plane trip. They don't want to take medication all the time, but they just want something short-acting. Or other people might have different requirements, or they might have, say, for example, significant constipation, and therefore mirabegron, which is not constipating like the antimuscarinics, might be a better choice for them. We tend not to prescribe oxybutynin because antimuscarinics, they act on the muscarinic receptor, and the muscarinic receptor can be found in a number of different places in our body, including the eyes, mouth salivary glands, the bowel, obviously the bladder. That's where the common side effects of dry mouth, dry eyes, and some constipation effect comes from. But also, it can also be expressed in the brain and the hippocampus. And so the reason for choosing a selective antimuscarinic or one of the medications which is a big molecule, so it doesn't cross over into the brain, is important to consider with neurological conditions. And so that's the reason why we tend not to prescribe oxybutynin in case of a theoretical risk of affecting cognition and thinking and memory. And so go to another option, which is called tibial nerve stimulation. And this can be really popular if you take a lot of medications, you don't take any more, or constipation is a really significant issue. And so this is where the posterior tibial nerve is stimulated, either with sticker electrodes, the furthest away picture, or with very slim acupuncture type needles. And it's a once a week treatment. And the way that this works is that the posterior tibial nerves is a mixed nerve, so it's motor and sensory, and so it's what we call neuromodulation, so that if we provide some electrical current that goes back up the nerve and it modulates the signals coming from the lower part of the spinal cord to the bladder. And that's the theory of how we think this helps with particularly urgency and frequency. And in terms of if people have a neuropathy, what we do in our service is that we'd do a nerve conduction test first to see if there's any nerve dysfunction. But we've actually found that some people with the PTNS, which is with the needle type, will still have some benefit from the treatment, even though they have reduced peripheral nerve function. And so we do a 12-week series of treatments once a week, and then people would return for top-ups if they find that helpful. The kind of benefit with the sticker type electrodes is that people can do it at home, so it's more convenient. Bladder botulinum toxin is effective for some people who have detrusor overactivity, so they may be refractory, the symptoms refractory to tablet medication, to tibial nerve stimulation, and therefore looking at botulinum toxin to inject into the bladder is helpful. We're familiar with it cosmetically to paralyze muscles, but it does exactly the same thing in the bladder. And the effect can last up to 9 months. People do need to know how to empty the bladder with a catheter, though, about 20% of people will go into retention. And then lastly, I've put in about sacral neuromodulation, because I think someone had a question about this last time. And so this is a relatively new treatment looking at managing bladder overactivity, and it's currently used for what we call idiopathic detrusor overactivity. Its use in neurological conditions we don't quite know yet. So there was a this is the largest study that's been done. This was in Zurich 2 years ago, and you can see they looked at quite a number of different neurological conditions, and overall there seemed to be a sign that this did help with managing lower urinary tract symptoms. But the principle of sacral neuromodulation is the same as tibial nerve stimulation, and that there's modulation of the sensory nerves with the idea that by stimulating that dampens down the expression of the nerves going to the bladder. And you can see some people call it the pacemaker for the bladder, and involves an operation with a small pacemaker-like device and then leads that go into the lower part of the sacral nerve roots. But this is, I guess, an area of possibly future development in neurologic bladder. And so I'll just mention quickly about some of the appliance and continence products which some people are very familiar with, and it's really individualised onto what suits your particular needs. So for example, some people might just use a convene, which is a condom-like sheath, say going for a long journey or overnight to prevent needing to get up out of bed. So lots of different options, and also when it comes to the selection of catheters as well, it's also very individualised in terms of dexterity, in terms of the particular needs of a person. And so in terms of permanent catheterization, it's usually either urethral or suprapubic, and this may be required if there's difficulty emptying the bladder, and intermittent self-catheterization may not be an option for various reasons. And in the long term, we tend to recommend suprapubic catheterization due to reducing the risk of urethral meatal damage. And so I just, in my last minute or so, this is it looks a little bit of a complicated algorithm, but this is going to be part of a paper that hopefully will be coming out either at the end of this year or early next year, which is a uroneurological guidelines for the neurologist in the clinic, the general neurologist in the clinic. So we hope this is going to be really useful. It's been part of quite a working group from the UK and across Europe and South America to develop this, because the symptoms of bladder, bowel and sexual dysfunction are really common, and often in a neurological clinic it can be difficult as to even to know where to start. And we've written these guidelines in order to aid the general neurologist in the clinic and the neurologist in the clinic, so hopefully this will help to identify and give more of a pathway for bladder symptoms to be recognised and then treated in order to help obviously people coming to the clinic. And really these symptoms are common, but really an individualised approach to management and assessing these symptoms is really important. And it's kind of symptoms below the belt can sometimes be difficult to talk about, but I really hope that some of this information that you can take away and maybe take to your next appointment can be helpful. And just thank you to the Alex TLC team for inviting me, and obviously feel free to email me or with any questions, or talk to me afterwards as well.